Okay, this is just one example, and not comprehensive for all of them, but basically, most of your mobile C-arms are going to have the same types of things. There's going to be a panel on the front with different types of controls. Most of these are self-explanatory, you hope. Things like the timer alarm, on and off, rotation, changing. If you've got dual monitors on your mobile, it'll let you change images from one to another, reverse, collimator control, some other types of orientation things. And then a lot of them have this central thing, which depends on what pre-processing or post-processing testing you want to do. This will light up and you'll have various control keys for doing this. Each manufacturer does this different. Some of them have distinct buttons that you press for these things. Others, you have a window like this for you to look at. Usually there's handles off to the side. These are steering for wheels. So either it's a handle or some of them are just grips. And we'll get some more of those types of things. These are pretty sophisticated. Some places are still putting recorders on them. Even in this day of where everything goes through to a central PACS digital storage, there's still some places, doctors being what they are, want to be able to have their own, some on videotape, some on disc. So if you see something like this, it may be weird, but most of you should probably be seeing nothing there. Down here, there may actually be a printer. Surgeons still like drawing on things. I don't know why, but they do. That's about basic components. You can activate your fluoro either from the control, or there would be a pedal down here that allows you to do either a spot film or activate fluoro. For your monitor displays, you would have your keypads for doing demographics and other information. This is a color printer that orthopedists, I don't know why they really love these things, but they do. So if you see something like this, that's what that does. This is the tube housing. This is an extension cone. Just to let you know, for state law, if the extension cone for this is an attachment where it comes off and on. Okay. A lot of surgeons will take this off so that this fits under the surgical table. Please know that when that exam is done and you roll that equipment back out into its storage location, that has to go back on. It is against California law to store a C-arm without the extension cone affixed. So that was a ruling the state made, God, what, 15, 20 years ago. The problem with leaving it off is what they can do is they can permanently require you to attach those. So if you're a consistent violator of putting these back on, your facility may be ordered to permanently affix them, which then means that unit would no longer be possible to be used for certain surgical applications. Okay. It's not really seen here, but there are brakes on wheels. Those are manual brakes. We'll go through some other things. So that's basically the kind of system. You can see things much better here. This is a manual switch for activating fluoro. Most places like to use the step paddles. These are manual locks. There are manual locks on usually tube motion. And in this case, the steering wheels are done by the handles off to the side. It takes two people to move these. This doesn't weigh quite so much, but these are very heavy. generally. You'll notice a definite drop when you put it into the elevator if you move one. This is an image intensified type. So you've got your image intensifier, which takes up basically all of this, and then you've got your optical, and this would be using a CCD camera. Very compact, easily cleanable. I don't know how often they do get cleaned. This is a different type of head. This is where the required distance is built in to the housing, so there's nothing to take off or put back on, so you don't have to worry about that. But everything is in. A lot of these newer ones has not only the tube, but a lot of times in some of the newer units, part of the generator is actually in there. The high voltage system is in there as well. Generally, you can see where the focal spot is. And of course, that's to make sure that you meet the requirement for distance from the focal spot to the entry of the tube. We'll talk about that. This is another example where the controls are a little bit better explained. Usually you'll have your technique shown. Again, image rotation, right and left, reversal. You can save workstation swap, so you've got dual monitors. Change the modes. Collimation is here. Different types. You usually have blade types that can also rotate. You also have apertures involved. You've got some auto controls. In this case, this particular case, it's auto contrast. Other systems have other types of things. KDP, MAN mass. You've got pulse, you've got low dose, auto, and that's your alarm reset for this particular device. Like I said, every manufacturer has their own little tweaks and things like that. This is a close-up of the manual brake. They both need to be set. And these are your manual controls for rotation of the gantry, and each other type will have its own manual controls. That's the thing to remember, that on C-arms, mobile C-arms, all of the locks are basically manual locks. There are very few systems that have any automatic electromechanical locks like we have on our fixed equipment. So you have to remember where all the locks are and make sure that they're on or take them off before you try to move it. Mobility. Pretty good. Allows you a lot of flexibility when you put this into a surgical environment. You don't have to get it exactly in the right place. So you have orbital rotation. That would be the C-going orbital. And typical is 115 degrees. Maximum is around 165 degrees. Take that back. Let me back up. Orbital rotation. Yeah. Orbital rotation is where the C goes this way, sorry. That's 115 degrees, or maybe 165. Horizontal axis rotation, this is where the C goes around this way. Mostly it's 180 degrees. Some manufacturers go to 210, others as much as 270. And there is a hard stop when you get to that end. You want to know what those are. Telescoping, this is where you move the C in and out. Average distance is typically around 20 centimeters. Some manufacturers a little more, some manufacturers a little less, but that's a good estimate. Side to side, what they call wig-wag, that's where the C goes this way. Typical is plus or minus 12 centimeters, plus or minus 26. So it's not a lot, but it allows you to do some. It means you get it close enough, then you can make fine adjustments depending on where the patient is. Height adjustment, typical height adjustment is about 46 centimeters. Okay. So again, these are typical. If you're going to use systems in your facility, I would suggest you find the operator's manual and look on the technical specification page, and it will give you all of these so you kind of know what the limitations of your piece of equipment are, so you don't do anything unexpected. different type of a system. This is where it's kind of all nice and built in. This is a real nice surface here because it's waterproof, so you can just wipe all of this off. Again, two dual flat panel displays. So there are all sorts of different variations of this. Again, printer for those doctors that still insist on that. Some other types of controls. Here you've got something that allows you to change the noise and do some other enhancement. You have a zoom factor. Again, swap. This is blank is when you've got two monitors and the physician only wants to use one. So you use the blank to actually blank one of them, so it doesn't confuse the issues. You have a brightness adjustment, contrast. Then you have patient information, image directory, and other types of things. This is kind of an all-in-one type of control console. So they're all very different. I don't know any hospital that consistently buys the same model and manufacturer of equipment. Usually purchasing is based on who's giving the best deal at the time based on what the hospital needs are. So you may have a bunch of equipment that needs to be replaced and you go out to bid, and let's say, for example, General Electric gives you the best bid. So that means all the C-arms and other things you're going to get for that particular year are going to be General Electric. The next time it's time to bid, based on the type of equipment, maybe Philips is going to give the hospital the best deal. So now you're going to get a whole bunch of Philips equipment in. So you are never going to be fortunate enough, except in a very small facility, where you're using the same manufacturer of equipment. This is a mini C-arm, usually used in a cast room. Anybody ever used a little one like this? Yeah. Big problems with these. Number one, none of the pieces or parts of this are balanced very well. On the larger C-arms, everything is counterbalanced pretty well. If you undo a lot, it's not going to go flipping around. Nothing horrible is going to happen. If you flip a lock on some of these devices, things happen. Usually not good things, usually things that trap your finger or some other body part that you don't really want to get pinched. For example, on this unit, the X-ray tube head, the generator is actually partially up here because it's digital, it's electronic. So the difference in weight between this and this is extreme, and there is no counterweight on it. So when you let this go, if it's not in a nice balanced position, it's going to swing to where the weight is. So you have to watch that. Same thing for these arms. Again, these are all manual locks on these articulating arms. You need to be very careful when you unlock that it's not just going to flop. I've seen them where it gets unlocked and this whole C just kind of swings down, and unfortunately there's not enough distance between that and the floor. That was not a good situation. These are getting a bit bigger. The original one of these was a 4-inch image intensifier used in the cast room for making sure that fractures were reduced and that after casting. The newer ones are up to 6 inches field of view. But what's interesting is the MA is in not milliamps, but microamps. So it's a very, very low dose system. A lot of people refer to these basically as like toasters. Anybody can do it. There's not a lot of adjustments you can make. Basically just KV, MA, a couple of basic types of things. Used a lot in cast rooms. The danger with this is California law says that a certified radiologic technologist with a fluoro permit or a supervisor and operator are the only ones who can legally operate these. And what you'll find if you go into any cast room, I guarantee, I don't care what hospital it is, walk into a cast room, I guarantee at some point you're going to see a cast room tech operating these. You just need to let your supervisor know what you've seen. They're probably aware of it, but because it's very difficult to control, but yeah, that is illegal. I've seen nurses doing it. Again, there's also locks on the wheels, and those are manual. Okay, so talked about all sorts of different fluoroscopic scatter. I think the thing to remember is you have to just consider how much attenuator is between you and the beam. So in this case, this is a torso phantom. If it was a human, even with the legs, I don't know that it would do too much to change this. So you've got most of your attenuation from the mid-chest to the bottom of the torso, top of the head. So that's what these big dips are, because there's a lot of material there attenuating that scatter. However, on this phantom, which is fairly small, you have very little attenuator side to side, so you get these what I call butterfly wings. And the other thing to remember is difference between anode and cathode. Okay, you get to see some slight difference, and that's because of the heel effect. Okay, so that's one dimension. There's another dimension, eye above, X-ray tube below, and again, you see the effect of the heel effect. And you can also see in this particular case, the closer that the image intensifier is to the body part, these come down significantly, so there's very little, if any, exposure back above the image intensifier, but most of the scatter is down at the feet. One of the reasons for having a drape, as we showed in a previous lecture, makes a lot of difference. But on your mobiles, not all environments using a mobile are going to have drapes available. So you just kind of have to be aware of what it is. Okay, from the side, it's a little bit different. Again, you can see your exposure essentially drops down to zero, and all of the scatter is back towards the X-ray tube. Digital photo spot exposures, typical is 1 to 20 milliseconds per frame. Some values that are probably still good, about 50 MR per frame for 14-inch, 120 MR per frame for 10, 280 MR per frame for 6.5. That's what the patient gets, and that's due to the fact that the exposures are based on what the image intensifier needs to see. So the manufacturer sets these up in such a way that the amount of information, the gain, the amount of noise that you get in your images are set. So there's actually specifications for this. For this particular unit that I used, 30 MR per frame is what you needed at the surface of the image intensifier to give an acceptable image. So that went from 30 to 80 to 180. So taking what was needed here, that translates to, notice you're going from micro-R now to MR. This is what the patient gets, because you have to take into account table and attenuation of the patient. This is a different type of C-arm, believe it or not. This is an O-arm. Anybody here seen one in their facility? Kaiser, I know, has them. This is actually classified as a C-arm because, I don't know, I'm not quite sure how they managed to do that, but because within the shroud is a C-arm that just happens to rotate 360 degrees. So it's like a, you could call it a poor man's CT. What's interesting is I don't think a lot of these are being bought currently because shortly after this was introduced and people were buying them because of orthopedics and neurosurgery, portable CT became available and cost effective. So a lot of hospitals started with these and then have switched to portable CTs. And again, it's like this. You push it into the room and you can actually do a CT scan. These are very heavy. You're going to get your workout pushing these around. But it's nice. This is the type of work you can get. Neuro work, it's very exacting. It's not the best CT scan in the world. It's not the best cross-sectional scan in the world, but it allows you to accurately pinpoint various parts in the neurologic system, the spine. Surgeons love them. Me, not so much. From a radiation point of view, it's like having a CT in the room. In fact, the manufacturer documentation that comes with it recommends that during an acquisition, that the room be cleared, that you not even stay in the room. Obviously, you need a shielded room. Notice the one safe place, though, is at the one side of where the console is. There's essentially very little exposure there. Usually the surgeons will stay there. But the patient orientation is this direction. So the surgeon might be pretty good standing there, but who's caught in the crosshairs? Who can't leave? Oh, you can leave. Techs can leave. You don't have to stay in the room. Anesthesiology. They can't go anywhere. So they should not only have a rolling shield that is clear. It should probably be one of the shields from nuclear medicine because there's more lead in it. Because they need to keep a watch on the patient the entire time. They're usually right up here at the head end. There's not much that they can do. But you have an appropriate shield, they're perfectly safe. The dosimeters for the ones that I looked at were all within limits that I would expect them to have. They were perfectly safe. They just feel a little weird being in there. But yeah, so that's kind of the situation with those. Okay. Any questions about mobile equipment? Yes.
Yeah, so when you don't do a spin with the O-arm, but it's just a spot, like a lot of techs are saying that during the spin, you know, we're behind the shield, right? The one, like the door. During the spot, they're like, well, it's just the amount of radiation, like almost regular X-ray. Is that the case?
Well, if they're doing a spot, yeah.
Yeah, just so the spot is just like the regular X-ray. That's what they're saying. It's not much more.
Yeah. So where are you standing during the spin?
During spin, behind the leaded rolling wall.
Within
the room inside.
So put the leaded wall in that rear area, and
Here?
we're also wearing lead, and we're spinning in the anesthesiologist.
And how many people are back there with you? That's a pretty small...
Everyone leaves except for us and anesthesiologists.
Everyone leaves except for you? The surgeon leaves?
Yeah, they all leave.
The surgeon leaves?
Yeah.
Oh my
Yeah,
God.
they all leave. The only one who stays is us with techs, anesthesiologists, and we're literally there at the rear, and plus the rolling that's shield, and we're behind it.
If you're here, you're safe. I'm not worried about that.
Cool.
What bothers me is the fact that a surgeon leaves. Anyway, never mind. I'm not going there.
It means he trusts us. So.
You have to understand this. Do you remember your medical law and ethics class, or did you take it?
Oh, of course I did. It was a while ago.
The problem to have a physician leave the room, when you think about it, a surgeon especially, minute he or she turns their back on that patient and starts walking out, anything happens to that patient while they're out of the room, they are liable. Okay? They have the responsibility. They're the only ones with the responsibility to be in the room to make sure that that patient is completely safe. They can say that they're delegating that to the anesthesiologist, but all he's doing is making sure the patient can still breathe. The patient codes, yes, he's going to issue a code, but now you got to wait for the physician who's standing outside, who's probably talking or doing something else, to realize, oh, my patient just coded. Anyway, that's just weird. I'm sorry. Sorry. Crazy. Any other questions about C-arm? Okay, so that was a lot of fun.
Yeah. They trust us, dude. They trust us. Because we deserve respect. Actually, yeah. I mean, like, I feel like surgeon needs respect. Nothing is gonna happen.
Okay, so what I'm going to hand out now.
Do you wanna? Yeah.
Anybody